I'm excited to introduce BJ. He is with the state and the state asthma program. I'll let him give a bigger introduction here of who he is and all of his work, but it's been wonderful to work with so far. Has a long but awesome presentation in here. And then again, the slides and then the recording of this will all be available afterwards as well. So BJ, the floor, it feels weird to say the floor, right? Because we're not in person, but the virtual floor is all yours.
Sure. Perfect. Thanks, Kate. All right. Well, I don't know if there's a whole lot more of an introduction. I am the program manager for the Asthma Control Program with DPHHS. I've been with the program over 10 years now in different capacities, but yeah, we have a lot of great strategies, and we've supported schools over the years. I've probably worked with a few of you on, I can't see everyone on here right now with my screen view, but I've probably worked with several of you over the years. So today, I'm not going to get into a training on a basic pathophysiology of asthma. I mean, you all, if you're in school health services, you're going to know a bit of that anyway, and we're not going to cover that in a 30-minute presentation, but I'm going to talk to you about the resources that are available, impact of asthma on Montana youth, and then some of the best practices and policies that are out there to help school personnel, to help students and families with asthma. So these are the objectives. I kind of touched on these first. By the end of the presentation, you'll be able to understand the impact of asthma on Montana youth. Second, you'll be able to recognize policies and practices relevant to providing safe learning environments for students with asthma. And then finally, you'll be able to identify available resources that can support school staff in their efforts to care for and empower students with asthma. So with that, I'll just jump right into the impact of asthma, both and a little bit on the national level and then drill down to Montana data. So in the United States, nearly 27 million people have current asthma. This equals about 1 in 12 or 1 in 13 people, right in between there. This breaks down to a little over 22 million adults and over 4.5 million children. But then when you take into account everyone who has ever been told that they have asthma in their life, that number jumps pretty considerably. But we look at current asthma for most of our statistics. Asthma is more common in female adults than male adults, around 11% compared to 6.8% of males. And then it kind of is reversed. We see that reversed in children. So asthma is more common in male children than female children, with around 8.4% of male children having asthma compared to 5.5% of female children. Every day, on average, 10 people in the United States die from asthma. In 2022, 3,235 people died from asthma. Not really, and we look at those as almost all avoidable, preventable deaths with the right treatment and care. So any asthma death is too many. So that's one thing we'll kind of talk about. Treat a little bit of touch on treatment and then resources to help folks get their asthma under control, avoid those really preventable deaths, of course. And then 40,000 plus people miss school or work due to asthma every day. So in Montana, 12% of adults have asthma, 7% of children. That's that current asthma. If you can see here, it might be a little bit small, but in Region 2, that's north central Montana, there's a slightly higher prevalence overall. This is when you just combine adults and children, but it's really not, that's at 13%. And so then we see about 11%, 10%. So really not too much of a difference there, even in the highest prevalence kind of chronic disease region. Then the lower right corner, you can see the home visiting map that displays our local contractors who implement our asthma home visiting program. It is available, that program is available virtually statewide, and we'll talk a little bit more about that later on in this presentation. And we do have the actual in-home, in-person home visiting in those kind of blue counties. The other thing that you see on this infographic here is emergency department visits and hospitalizations. So those are the total charges that we see related specifically to asthma on a yearly basis. This was in 2022. So those numbers don't change a lot, although the average charges for hospitalizations and emergency department visits have continued to go up. But we have one positive thing is that we have seen total emergency department visits go down year over year for the past several years. So we like to think we have something to do with that. Okay, so next up, when we look at overall asthma prevalence, Montana has a higher prevalence than nationally at 11.8% compared with 9.8%. In Montana, there are a few significant disparities that we pay close attention to. Montana adults with when I'm reeling off this kind of information here, this is adults because this is the data that we have from the behavior risk factor surveillance system. And we really only have enough results to display this information for adults as far as kind of these different breakouts. But there may be some translation there to how this applies to kids as well. So Montana adults with disability, they report having current asthma at more than double the rate of those living without a disability. American Indian adults more frequently report having asthma than their white counterparts. Montana adults making less than $25,000 are more likely to have asthma, as those making $50,000 or more. And then finally, the LGBTQ plus population also experiences higher rates of asthma prevalence. Okay, I'll get my slides to advance here. Okay, and then so using that same BRFSS and asthma callback survey data, we can look at asthma control in Montana. 27% of children with asthma in Montana report symptoms indicating that their asthma was uncontrolled. When we look at control, we're talking about symptoms. So we look at symptoms like coughing, wheezing, chest tightness, shortness of breath during the daytime, and then as well as nighttime waking is due to these symptoms. When measuring control, we also look at rescue medication and how often that's used. 43% of children with current asthma report limiting their activities due to asthma. So while some of these children may not be experiencing symptoms at the same rate as others, they still might be adjusting their behavior and possibly missing out on certain experiences or activities because of their asthma. So that's still something that we like to pay attention to. And then 1 in 4 children with asthma reported having to miss at least 1 or more days of school in the past year due to their asthma. The other data source that we often look at, which many of you are probably well aware of, is the Youth Risk Behavior Survey. From the most recent YRBS results that we have available to us, we can see that the self-reported prevalence of asthma among among high school students, is over 4% higher than what we see on the BRFSS and asthma callback surveys. It's around 11.4% versus that 7% that we see. And then it's even higher when you look at percentage of students that have ever been told that they've had asthma. So still kind of tracking with what we see elsewhere. We can also still see that the higher prevalence among Native Americans is still observable in this data as well. And then some more YRBS data here, just looking at percentage of students who miss 1 or more days of school because of their asthma in the past 30 days. What we see here, what we see here is that among Native American students and Hispanic students, they miss school due to asthma at a much higher rate than their white or multi-race counterparts. We also see a slightly higher percentage of boys missing school than girls. And then looking at the past 30 days, only 3.5% of students have missed time due to asthma. The biggest issue with this data point is that the YRBS is typically conducted in the spring semester between January and July. So as asthma triggers and control can vary throughout the year, this doesn't really provide a great snapshot of how much time may be missed. So we really like to look at it more on that whole year level, rather than just the past 30 days. But this is the data we have. And then based on other patterns that we see in healthcare utilization, it's likely that most of the students missing these school days due to asthma are going to be those students with more moderate to severe asthma. Doesn't mean those with more mild asthma can't miss school days as well, but what we typically see is those frequent flyers in the emergency department, and then that tends to be the case with those missed school days as well, those kind of frequent flyers. When we do a deeper analysis of healthcare utilization, we see that children experience higher rates of emergency department visits due to asthma at around 6.9 persons per 1,000. We compare this to adults, and adults are actually around 2 per 1,000. And then in terms of, or that's hospitalization, excuse me, I'm mixing these up. And then 9.7 persons per 1,000 for emergency department visits. And adults are still around that 2 per 1,000. So just a much higher rate, much higher healthcare utilization for youth. And then when we kind of take the averages over the last several years that we can look at, we see about 1,800 ED visits per year related to asthma in the state, and then around 256 hospitalizations per year. The other data source that we have access to here in Montana is the school health profiles. There are a handful of questions related specifically to asthma policies in Montana middle and high schools. So just some of the data that I pulled out from that, there's around 90% of middle and high school that say they routinely use school records to identify and track students with asthma. So I'm sure most of these do that. I'm surprised that there's even 10% that don't have some kind of tracking there, but maybe they just don't. Maybe it depends on who's answering that question. And then only 15% of middle schools and 11% of high schools provided parents and families with health information designed to increase knowledge around asthma. So that may be an area that we could certainly focus on, getting more materials out to schools to then distribute that to families as needed. And then the last set of questions are related to lead health education teachers. In these middle schools, about 19%, or about 1 in 5 lead health education teachers say that they've received professional development on asthma, while around 61% indicated that they would like professional development on this topic. And then in high schools, 17% have received professional development, while 46% say they would like to. So this may not extend perfectly to the desire of all teachers and staff, but I think these responses clearly indicate a gap and kind of a need or a desire for more professional development around asthma. So now that we have that little bit of background, try to get through that quick, I'd like to transition to asthma-related laws and school policies. So the first thing that we'll talk about is are the DPHHS school administrative rules. This is ARM 37.111.8. This is under public accommodations. The purpose of the administrative rules section is to protect the health of individuals. This includes students, staff, and visitors working in or attending schools in the state of Montana. So DPHHS is actually authorized by the Montana legislature to establish these administrative rules. That was set into place, many, many decades ago, with the last update to these rules prior to 2020 coming in 1986. So we'll talk about some of these subcomponents, but really what we were trying to do with this rule update was to bring a lot of these arms into the 21st century and kind of match them up with more current laws and other best practice policies that were already taking place in schools. So we weren't trying to burden schools with a whole bunch of extra regulation, but just say, okay, smoking only in the teacher's lounge, that can't be an administrative rule that the government owns and upholds. So we got to get rid of some of that and just update that. So these rules apply to private schools and tribal schools as well. So any schools accredited by the Board of Public Education, they must comply with these administrative rules. And while they are fairly comprehensive, I'll only touch on the arms that are related to asthma here today. The last piece I'll say about this kind of intro is the Montana Children, Family, Health, and Human Services Interim Committee within the legislature oversees DPHHS, and that includes their administrative rulemaking activities, ensuring that the rules are created and enforced according to law. So with this set, like I said, that they were updated in 2020. This is after about a 1.5 year long process of working with some school administrators, some school health professionals, as well as educator advocacy organizations like Montana School Boards Association, Montana Rural Education Association, OPI, and others to bring these rules into the 21st century. So with that, the first section is health supervision and maintenance. So what you need to know about this section is that schools are required to develop and enforce policies on first aid. So check. Most of you sure are doing that, or all. The change in 2020 was the requirement that schools include procedures for responding to chronic disease exacerbations such as anaphylaxis, an asthma attack, or hypoglycemia. So just having some kind of procedure and policy written down so when there is turnover in the school, that's there for the next administrator, next school nurse, next person that comes in. In this section, another small change was made requiring that no tobacco signage include electronic cigarette language, and that the language be posted, or that the signage be posted at school building entrances and be clearly visible. So again, pretty common practice, and just trying to align that with tobacco laws like the Clean Indoor Air Act. The next two sections of interest are entirely new sections on air quality. The first is indoor air quality. It's quite short, only requiring that HVAC systems have filters that meet minimum efficiency standards in schools, perform annual internal indoor air quality inspections. So this also includes inspection of HVAC systems. So these simple walkthroughs can really help identify potential asthma triggers, but even more importantly, these types of inspections really help reveal small built environment issues before they become bigger problems. So if you are specifically in school health services, you may not really be involved in the in these inspections, but just knowing knowing that these rules are on the books, that schools are supposed to be complying. So when you have those conversations with administrators, or if you're an administrator, knowing this and then having a plan for how to do these walkthroughs and why they're important for your students. Then this is just that indoor air quality walkthrough inspection checklist. Just kind of a little snapshot of that, looking at different, again, those different built environment pieces within the school. Question. Okay. And then the next one is outdoor air quality. So in the outdoor air quality section, there's two main components. The first is that schools must reference the outdoor air quality and activity guidelines. These are developed by DPHHS, DEQ, and OPI. So they must reference these guidelines when determining to delay or cancel school-sponsored events. Now, that doesn't mean that this is a regulation that schools have to, if a number is in the unhealthy category, that they have to close everything down. These are recommendations. So the requirement is that they must reference these, and then just so they at least have some informed idea of what the air quality is and what the health categories are, how that impacts people with asthma and other sensitive populations. So these guidelines are widely available. They can be found on the school health website. That's schoolhealth.mt.gov or airquality.mt.gov, or they're also on DEQ's air quality web pages as well. The second component is that schools must have a written protocol for minimizing the infiltration of outdoor air into school buildings to the best of their ability during poor outdoor air quality conditions. So I'll go to the next page here. This is just kind of a modifiable example policy that's available for schools to use. Again, might be kind of hard to see all the details of this, but we do have this on our website in a couple different places. But this just gives practical steps that schools can implement. So it's putting up some signage maybe on exterior doors to keep those closed and not have them propped open during poor air quality events, using portable air cleaners, or at least creating some clean air spaces like a library, cafeteria, gym where larger groups of students may go and may be able to spend some time and find respite. So again, this is just an example. The Montana School Boards Association has adopted this in their school wellness policy that many schools use. So I have seen this in some instances out there, but it isn't required to look exactly like this. We want it to work for schools and be something that they actually follow. And then this is just a blown up version of the outdoor air quality and activity guidelines. So won't spend a whole lot of time, but you can see how that kind of works. Okay. So shifting now from school administrative rules, those are the ones that were really relevant to asthma and air quality. So now I'd like to point out a couple of laws that are specifically focused on asthma management in schools. The first being MCA 20-5-420. This law allows students to self-administer medication for asthma, severe allergies, and anaphylaxis. This law was enacted all the way back in 2005. And then under this law, schools may not deny students the right to carry their asthma medication and self-administer that if legal self-carry authorization is completed and on file in the school. So I'll jump ahead here. So this is the actual, on the right, this is the form. Again, kind of hard to see on this screen, but that form really can't be altered. That's what it needs to look like. That's enshrined in Montana code. On the left is the Montana Student Asthma Action Plan. We have this double-sided asthma action plan self-authorization combo form. I've seen others out there as well. There's different school systems that like different asthma action plans. And those are really helpful. If you haven't ever seen one or used one, they can really be helpful for teachers, administrators, and other staff to better understand a student's asthma and how to respond in an emergency. So have some key information on there. And again, that can be edited. You can play with that so you can have what you'd like, but self-authorization form cannot be. Okay. The latest asthma legislation was passed this session and signed into law by Governor Gianforte on May 1st, and that is stock albuterol. So stock albuterol makes schools safer and what it does not do is replace the expectation of a parent or guardian to ensure their child has their prescribed albuterol inhaler and self-carries that medication at the school. So students are, as you saw, students are allowed to do that according to that MCA 20-5-420. But we don't live in a perfect world, so students or staff, this stock albuterol can be used for staff as well, but primarily students are the focus. But if one forgets their inhaler or can't find their inhaler or unable to direct an individual to their inhaler due to their current level of respiratory distress, or an individual has no known history of asthma, or it's an unknown cause of respiratory distress, stock albuterol allows for an intervention to be available at the school. And one big thing I want to point out about albuterol is that it has a broad therapeutic index, high safety profile, and it's pretty simple to administer. I would say even less scary than administering epinephrine. So Consequently, complications are going to be rare. Trained school staff should be able to confidently administer medication without fear of harming a student or staff. Um, and then with this law, schools are not required to carry or administer stock albuterol. It just provides authorization for schools to stock and administer albuterol if they so choose. And then equally important, the law indemnifies the school district or non-public school against liability as a result of injury arising from the administration of stock albuterol. So those are some important pieces. School staff can be trained to do this, and that's part of this legislation is that they have to go through some kind of training that has the components. Those are listed off in the law, and that's something that our training, which I'll get to in just a couple minutes here, that we do cover all the components that would fit with this. But if a school nurse or other school health services professional or contractor were to provide that training, there are components that need to be covered. It's listed in this legislative language. Estimates from states that have successfully implemented stock albuterol, they show the average cost of procuring stock albuterol and the inhaler and disposable spacers can range from $25 to about $100 annually. So while there is not currently a funding source for schools to purchase these supplies, schools and school systems are encouraged to contact local pharmacies, healthcare provider organizations, parent-teacher organizations, or other local organizations who may have programs or resources available, and hopefully at that lower cost, that's something that there'd be a willing partner to help out with. Something to keep in mind with stock albuterol as well is there are hundreds of doses in a albuterol inhaler. And it's hundreds. I think it's less than 200, but ideally you're not using that all the time. This is for an emergency situation. So that should more than cover all the emergency situations in 1 year that arise. And I think that's, if there are any questions about that at the end, we can certainly get into that. But I think the last thing I'll say on that is that we are in the process of developing guidance here at DPHHS for stock albuterol in schools. So we'll have information on like what are the processes that you go through to reach out to pharmacies, or you have to have a provider prescription. So some of those finer details will be in that guidance that we're working on getting out this summer. So interested schools can kind of plan ahead for that 25-26 school year. Okay, so that brings me to support resources. So I touched on this. We do have the Creating Asthma-Friendly Schools training. This is more in depth. This is going to cover those kind of that background of asthma, and then get into the 7 steps to creating an asthma-friendly school with roles and responsibilities broken out by different kind of profession type in the school. This course follows the Creating Asthma-Friendly Schools guide that's created by the Asthma Control Program in the early days. The course itself was established in 2016 and has been updated multiple times to remain current, and we'll do another update this year as we add some of that stock albuterol information in there as well. The next piece that I'll highlight is school health mini grants. So over 70 grants have been provided over the last 10 plus years. These are $1,000 grants intended to support asthma related projects in schools. We have opened it up to diabetes as well. So there's an opportunity to do some diabetes projects or CPR first aid, but coming from the asthma program, we do like to see some asthma ones as well. There are some pre-designed projects to choose from. Asthma self-management curriculum, teaching that to students, or just a staff training. Another project is reviewing student health records and then referring students with uncontrolled asthma to the home visiting program. So kind of linking up those programs. And then along with that funding, which can be used for staff time, for training materials, and there are some other small uses of that funding as well. But Along with that, there are some other resources that typically come along with that. So like these kind of stock presentations that we have put together, and some educational materials for use in the school. The application period for these opens July 1st every year and remains open through March 31st or until the funding has been expended. School nurses, administrators, or counselors may apply. Also, if you work with public health nurses, they're eligible to apply for this as well, and you can kind of work together with them to implement a project. Okay, so trying to get through to leave some time for questions here, but I do really want to highlight our asthma home visiting program. This is kind of one of the crown jewels of our program. It's certainly probably the most data heavy. So the Montana Asthma Home Visiting Program, or MAP for short, was developed in 2010. It's a 12-month home-based program for people with uncontrolled asthma. This is built on evidence-based practices. Participants receive up to 6 visits from a trained healthcare professional to address asthma self-management education, triggers, care coordination, and then also an assessment of the home environment. So the program goals are to decrease the number of missed school work days due to asthma, decrease unscheduled office visits, emergency department visits, increase the number of at-risk adults and children with a written asthma action plan, increase the mean score on asthma control tests, and then decrease the number of days that participants are using their short-acting beta agonist medication or their rescue inhaler. Eligibility for this program is defined as children or adults that are residents of Montana and have had at least one emergency department visit or urgent care visit or hospitalization for asthma in the past year, or scored less than 20 on an asthma control test within the past year. Patients with an asthma diagnosis who don't meet these criteria may be referred into the program by their healthcare provider as well. So that's a really important caveat there, because people may really need that education and may need inhaler technique. They may be struggling with their lung function, but it's just not showing up the same way as a control test would indicate. So there are ways to get into the program with a provider referral. So as far as the map structure, I won't spend a lot of time on this, but what I'll say here is that the program can be implemented in person, virtually, or in a hybrid model. So you kind of heard, our participants get that home environmental assessment, they get that care coordination, and they also receive participation incentives like a HEPA air cleaner, replacement filters for that air cleaner, and then a spacer for use with asthma medication as well. This is just related to our home environmental assessment piece. So just some of the things we're looking for in the home: pet dander, dust mites, cigarette smoke, mold potentially. So they use a EPA home environmental assessment checklist specifically for asthma triggers, and they kind of go through that and do a walkthrough with the family, try to help them recognize those potential triggers. And then here, I don't need to spend a lot of time on this, but here's some participant outcomes. What I'll say is that we've had we're up to about 830 children that have participated since 2011 at this point, and over 115 adults last I looked, and that's since 2020. And the program has spanned 35 counties, but again, is available throughout all counties. And the results have been overwhelmingly positive, and that has remained the same all these years. Where we see those reductions in ED visits, we see the reduction in missed school and work days due to asthma. Okay, so lastly, how to refer. Referring to the program is simple. Anyone can do it. The MAP uses a secure HIPAA-compliant referral portal, which can be accessed from the asthma.mt.gov website. You'll see this little icon here that I have circled. This will be on every page of our site, and it'll also be on some of our local public health contractor websites as well. So when you click into this referral portal, what you see is two kind of these brief descriptions. You can come from either from these like two different sides, right? You can refer, you can actually do a self-referral, or you can do a provider or organizational referral. That's not limited. When we say provider, that's not limited to primary care or specialists. That can be from a nurse, that can be from a school, it could be from a social worker. So we don't really limit that. We just want to know who it's coming from, some of the basic information and that basic client information. And what happens is those referrals go to our home visitor and for that county. And then they'll follow up. That's the first thing. They'll follow up with the client. If it's a provider referral, they'll follow up with the provider first and then reach out to that client. If it is a self-referral, then the follow-up's a little bit different, but they first follow up with that client, and then there's a little bit of extra work to find out that they do have a confirmed asthma diagnosis. So they'll speak with that family or that client about who their provider is, and then do that outreach as well. So that's the home visiting program. And then I'll just say one last thing here, and this is related to air quality and wildfire smoke. Just as we go into this season, with the tail end is usually at the beginning of the school year there, but I just want to mention some resources available. This wildfire smoke response toolkit for schools was developed. It includes communication templates, social media examples and graphics, lesson plans around air quality and wildfire smoke, and then just some guidance on practical steps that schools can take to protect their indoor air. This is available at airquality.mt.gov. And then lastly, the EPA Air Quality Flag Program. So this is a free program. It provides different color flags associated with different air quality health categories, along with lessons plans to engage students around the topic of air quality. So this program is free. It's supported by Montana Health Professionals for a Healthy Climate. So you have classrooms that may be interested in doing some fun projects around this. It's a great program for that. And then that's about it for me. Here's some resources. And these links will be in those slides that go out. This is not an exhaustive list, but it's some that we trust, and there's some really nice toolkits and tools out there.